Hello, and welcome to my presentation comparing Canadian and American healthcare systems. Canada's healthcare system is a universal healthcare model available to both legal and illegal residents. Canadian government has more involvement in physician and hospital supply, budgets, and technology. Canada's single-payer system forces hospitals and healthcare providers to operate within a very strict budget. There is the absence of employer involvement except for the option of supplemental coverage, which is purchased by 80% of the population. More general practitioners exist in the provinces, covering an array of specialties in comparison to America's family practice physicians. The United States is one of the largest, most advanced, literate, developed countries in the world, yet has the highest healthcare spending per capita. The U.S. ranks 39th in the world for infant mortality, 43rd for adult female mortality, 42nd for adult male mortality, 36th for overall life expectancy, and 37th in developed world healthcare performance. The American healthcare model consists of employer and commercial insurance companies and Medicare/Medicaid government-driven programs. Most care, including preventive, is coordinated via primary care providers, which are physicians and advanced practice providers such as nurse practitioners and physician assistants. Primary care is the foundation of the U.S. healthcare system, required to meet what was known as the triple aim, accountable care, which is now referred to as the quadruple aim, of better quality, controlling costs, and improved patient experiences while reducing health disparities. Instead of patients overutilizing emergency rooms for non-emergent care, accessing preventive care is the model's objective. The Canadian healthcare team is comprised of an abundance of general practitioner physicians and a growing shortage of nurses. Nursing licensing is like that of the United States and includes registered nurses, nurse practitioners, nurse midwives, and LPNs. Advanced practice providers, nurse practitioners, and physician assistants are newer professions in Canada and not yet widely used. The United States healthcare workforce is highly educated and in large demand. The shortage of registered nurses has become a national crisis over the past several years. It is estimated that in 15 years, the U.S. will have a physician shortage of 200,000. This has led to the growth of mid-level or advanced practice providers, nurse practitioners, clinical nurse specialists, and physician assistants, all educated by at least a master's level education and employed at both primary and specialty care levels. For both countries, demand continues to increase, and in addition to aging populations, both are feeling the constraints of heavily costly healthcare delivery systems. This is especially true for Canada, where the universal healthcare model continues to concentrate payments of services to hospitals and physicians. Canadian Medicare, considered the primary insurance, is administered and run by each province or territory via tax-funded insurance plans and covers access to physician and hospital services. In 2017, total health spending was estimated at 11.5% GDP. Secondary insurance covers approximately 67% of residents for non-covered services such as dental, vision, outpatient prescriptions, rehabilitation, etc. Healthcare providers are paid fee-for-service, by capitation, or by salary. America is working towards more value-based care and reimbursement models based on patient quality outcomes. Instead of focusing reimbursement on fee-for-service, inpatient stays, etc., today's desired model looks at cost-effectiveness by implementing more outpatient services and promotion of preventive care to achieve best health outcomes for patients and viewing healthcare delivery with more of a business management mindset. Canadian healthcare differs drastically among provinces due to variances and disparities. The strengths of this type of unit include equitable treatment and payment for patients, providers, and employers, as well as flexibility in delivery of care. Weaknesses that are now experienced by Canada advise that quality and access to care are deteriorating while costs, especially to patients, are rising. Long wait times continue for elective services, inequitable access to services, and undesirable outcomes for poorer populations due to social determinants, especially in rural areas. Approximately 62.3% of Canadian physicians are located in the provinces of Ontario and Quebec, only 9% in rural Canada. Roughly 18% of Canadians live in rural areas and tend to be older and sicker. Although the U.S. is known for technological advancement and research, the delivery of equal healthcare has been poor. America has practiced delivering healthcare services in a fragmented fashion for decades and is learning that does not lead to high-quality, cost-effective, and valuable patient care. The development of the Accountable Care Act brought about a more holistic approach in caring for patients through implementation of value-based care and the requirement that all Americans obtain health coverage or pay a penalty. For both countries, social and economic conditions impact the health of the population. Access to care is also an issue these countries share, but especially for Canada, where significant wait times exist even for preventive services. Long-term care for older adults continues to be challenging for both nations. However, Canada's universal healthcare system remains a source of national pride and patient satisfaction rates are greater than America's. Overall, Canada has the basis for a successful and sustainable healthcare system that benefits all, but improvements need made to ensure long-term advancements, equality of care, and best health outcomes. The system continues to provide, but as predicted over 25 years ago, will not be sustainable in terms of today's healthcare. To increase value and equity of care, Blomquist and Busby proposed a more balanced mix of public and private insurers, with the government instead paying larger shares for drugs, long-term care, and preventive services, including dental, eye, and behavioral health care, and allowing more private financing for hospital services. To further ensure value for all patients, payment model standardization and systems integration, such as electronic medical records, should occur across all provinces and territories. Despite the implementation of the Affordable Care Act, approximately 40 million Americans are still without health insurance coverage. Of all the industrialized nations in the world, the U.S. is the only country without a universal healthcare plan. In past years, the U.S. was dominated by physicians' decisions, but has now moved to a more business-related model, as Harvard's Porter described, more about management, organization, and measurement. Reform continues to work towards controlling rising healthcare costs and achievement of affordable, high-quality care for all Americans. This concludes my presentation. Thank you for watching, and I look forward to your comments and feedback.